Establishing relationships. Providing information on establishing effective relationships with occupational therapy clients is the central objective of this text. As emphasized thus far, achieving an effective relationship is both challenging and vital to positive therapy outcomes. This chapter covers the most basic criteria for relationship building in occupational therapy. These criteria are critical to emphasize at the beginning of the relationship when a client is still deciding whether or to what degree he or she can trust your personal integrity and professional competence. The criteria convey to the client that you are willing to know the client as a unique individual and that you care about the course and outcome of the relationship. At the most basic level, your ability to relate to clients effectively requires you to have expertise in 5 interrelated areas: rapport building, impression management, and setting an emotional climate, mode matching and versatility, managing emotional intensity, judicious use of touch, cultural competence. Rapport building involves making deliberate efforts to make a client feel comfortable in one's presence to establish a common ground for communication. Impression management consists of intentional statements and behaviors that allow the client to begin to trust one's personal and professional integrity. The emotional climate of an interaction refers to the nature and intensity of affect and the style in which affect is expressed by the client and therapist. Mode matching and versatility was emphasized in chapters 4 and 7. It refers to one's ability to anticipate which interpersonal mode is best suited for a client at any given time and to apply modes flexibly as needed using mode shifts. It conveys to the client that you are willing to orient your interpersonal style to the client's and to respond in ways that facilitate honest communication and mutual understanding. Managing emotional intensity entails knowing how to react when clients exhibit pronounced feelings of sadness, anger, or anxiety. Judicious use of touch refers to knowing how to use touch that is intended to have interpersonal effects in a way that respects clients' boundaries and meets their needs for closeness or distance. Cultural competence incorporates one's knowledge of, respect for, and ability to incorporate the customs, behaviors, belief systems, worldviews, and healthcare practices of individuals with backgrounds other than your own. Each of these criteria is discussed in more detail in the following sections. In the activities section of this chapter, a quiz is provided so that you can test your knowledge of these concepts reviewed herein. Rapport building and impression management. Rapport building is an often used term that varies widely in definition. According to the intentional relationship model, rapport building is defined as one's deliberate overtures to make a client feel at ease, particularly when first meeting and getting to know the client. The aim of rapport building is to establish an initial routine and approach to communication that the client experiences as satisfying and comfortable. Compared to other interpersonal strategies advocated by the IRM, rapport building consists of simple topics of conversation and other basic interpersonal behaviors that allow a client to become familiar with who you are as a professional and as a person. The fact that these efforts may come across to the client as rather simple and superficial should not be confused with the fact that the timing and attitude with which they are delivered are essential to the client's initial impression of you. Because each client gravitates towards different qualities in a therapist, you can gain ground if you are able to anticipate and approximate a match to which the client might prefer an initial overture. Some examples of rapport-building efforts include making eye contact and greeting the client in an earnest, serious, straightforward, professional, or friendly manner, depending on the client. Asking rather than assuming the client how he or she would like to be addressed. Introducing yourself to the client in a way that you anticipate would be optimal for a therapeutic relationship. Some clients prefer the use of a formal prefix such as Miss or Doctor, whereas other clients prefer the use of his or her first name. In some circumstances, the use of a formal prefix is necessary to establish a professional boundary or to communicate that you expect to be respected by the client. With children, some therapists prefer to use a formal prefix along with the first name. This may be motivated by having a complicated last name or by the desire to soften the feel of formality. If uncertain, asking the client how to pronounce his or her name and practicing it until you get it right. orienting the client to the treatment environment, and educating the client about the setting and about any routines that occur within the setting. Making impersonal small talk with the client, commenting about the weather, the traffic, noting any interesting facts about the setting, talking about a benign television show, or commenting on any renovations occurring in the treatment environment. Asking the client how he or she is feeling today or how his or her day is going. Let the client know that you know a little something about him or her as a person, if appropriate. For example, if a client feels good about his or her referral source, you might inform the client about something positive that the referral source said about him or her. If the client has volunteered, been employed, or has achieved something significant, you might inform the client that you took the time to search the internet about what he or she does or did to familiarize yourself. Sharing some facts about yourself or about the way you approach therapy with a client. Each of these efforts is perceived differently by different clients depending on the unique preferences of the particular client. As with other suggestions provided in the book, these guidelines for rapport building should be applied judiciously within the context of the client's particular interpersonal characteristics, the goals for therapy, and any other relevant aspects of the treatment setting or environment. Impression management is an important aspect of rapport building. It consists of deliberate behaviors and statements that prepare the client to begin to trust in your personal and professional integrity. When clients arrive to the treatment setting, many have a pre-established notion of what they expect to see in the appearance, demeanor, and behavior of a healthcare professional. Impression management refers to your physical self-presentation, emotional self-presentation, ability to project a take-charge attitude and to function within the instructing mode when appropriate, a sense of pride and energy about your work, an approachable, non-judgmental attitude, an ability to establish and maintain professional boundaries. These aspects of impression management are covered in greater detail in other chapters of this book. A therapist with effective impression management is more likely to have an easier time establishing rapport with a client because his or her appearance and behaviors conform to what the client may be expecting from a healthcare professional. A therapist with poor impression management may cause clients to feel less comfortable or may cause clients to question some aspect of the therapist's ability to serve them in a professional capacity. Setting an emotional climate is another important aspect of rapport building because it frames how the client will experience his or her interaction with you. Moreover, it influences the emotional memory that remains with the client after having interacted with you. For many individuals, the feeling that they come away with after therapy is the most influential aspect of the entire experience. It affects what content from the session they remember and how accurately they remember it. An emotional climate refers to the nature and intensity of affect and the style in which the affect is expressed by both the client and the therapist. Generally, the emotional climate of therapy can be thought of as spanning a continuum of intensity. A high-intensity emotional climate is one in which the therapist speaks loudly, shows considerable affective expression, and conveys a lot of energy and animation in gestures and body language. Sometimes the therapist might even cheer, shout, or make other vocalizations to highlight what is being conveyed. High-intensity emotional climates are often evident in therapists functioning within the instructing or encouraging modes. A therapist in the instructing mode might repeat a certain safety reminder with the client. In doing this, the therapist may use a loud volume or an urgent tone of voice to emphasize its importance. In situations that demand it, a therapist might use a loud, firm voice combined with an upright posture, an athletic-type stance, hands on hips, or other nonverbal gestures to establish his or her role as a leader or authority figure. Alternatively, a therapist functioning in the encouraging mode might shout in joy when a client achieves a hard-earned goal. Conversely, a low-intensity emotional climate is one in which the therapist speaks with a moderate to low volume and in a neutral or lower tone of voice. The therapist uses few hand gestures and assumes more control over body language and facial affective expression. Low-intensity emotional climates typically accompany the advocating, collaborative, and problem-solving modes. Because emotions generally play a secondary role in these modes, they are placed in the background. Instead, the intellectual or cognitive content of the session is emphasized and is used exclusively. The empathetic mode is unique in that it is defined by one's complete orientation to the client's affect, thoughts, and behaviors. Thus, therapists functioning in the empathetic mode naturally match their own affective intensity to that of the client, and the emotional climate is defined by the client rather than by the therapist. Irrespective of the level of intensity, the nature of your affect and the style in which it is conveyed are critical in defining the emotional climate. As a guideline, the nature of your affect should always be consistent in one of the therapeutic modes. Otherwise, it runs the risk of becoming non-therapeutic. For example, although a disappointed or even irritated tone of voice may, in certain circumstances, be appropriate within the instructing mode, uncontrolled rage or hostility expressed in the presence of a client is never appropriate. Similarly, an affect that could be interpreted as sexualized is not consistent with any of the modes and is never appropriate in therapy. Mode matching and versatility. In previous chapters, the 6 interpersonal modes and their application within the IRM were described. I emphasized the importance of applying them flexibly in response to the client's interpersonal characteristics and in the light of the interpersonal event at hand. In this section, the pros and cons of mode matching and mode versatility are elaborated because the mode use is so central to establishing effective relationships with clients. Mode matching is defined as the therapist's common sense efforts to select a mode that is most likely to be coherent with the client's interpersonal needs of the day or preferred way of approaching the therapeutic relationship. Thus, a therapist using mode matching applies general guidelines similar to those presented in Tables 5.1 and 7.3 to select a mode that best fits the client's interpersonal characteristics and/or optimally responds to a given interpersonal event of therapy. In many cases, your first intuition that a particular mode is the right one for the client is correct. However, there are exceptions. Some clients are more interpersonally complex than others, and they may respond atypically to your mode of choice. Similarly, more than one interpersonal event may occur during a given therapy session, and this may require you to shift modes more frequently than usual. Thus, when mode matching loses its effectiveness, mode versatility is often helpful for managing these more atypical interpersonal circumstances within the therapeutic relationship. Mode versatility relies on your ability to execute mode shifts, a skill introduced in Chapter 7. Mode versatility extends the concept of the mode shift in that it describes the process of trial and error undertaken by a therapist when shifting modes. The aim of this trial and error process is ultimately to identify the best fit mode for the client at that moment in time. To achieve this, you must possess an ability to monitor and read a client's reaction to a particular mode and then utilize the client's reaction as feedback to guide whether to remain in that mode or try a different one. Mode matching and versatility of mode use both lie at the core of the IRM because they allow you to be maximally in tune with and responsive to a client's interpersonal needs at any given time. These efforts convey to the client that you are willing to orient your interpersonal style so that the client is unencumbered by interpersonal concerns and better positioned to get the most out of his or her experience in therapy. According to the IRM, an effective relationship is not a perfect one. Thus, the ideal in a mode matching and versatility is not to be able to read the client's mind to predict which mode is the perfect match at any given time. Instead, the goal is to be versatile enough in your efforts and astute enough about gathering client feedback to gradually approximate the best match. Generally, when a mode matches a client's interpersonal needs, and provided that other elements of occupational therapy have been executed effectively, you may observe any or all of the following in the client's verbal and nonverbal communication. Relaxation of facial muscles and other body muscles, particularly in the hands, neck, and shoulder region. Signs of increased interest and/or engagement in therapy. Increased ability to attend to and concentrate on activities and tasks of therapy. Signs of appreciation, respect, or endearment towards you. Any of these behaviors indicates that the client feels comfortable and content interacting within a certain mode and can proceed with tasks and activities of therapy. When your mode choice is not optimal or you do not consistently try to approximate what might be the best fit mode for the client, clients do not generally exhibit these behaviors. Managing emotional intensity. There are occasions during occupational therapy when clients experience emotions that may be painful, stressful, or upsetting. These difficult emotions may occur in tandem with other certain behaviors, some of which, if prolonged or intense, have the potential to interfere with therapy or disrupt the relationship. 3 of the most challenging emotions that clients may exhibit include sadness, anger, and anxiety. This section reviews each of these categories of emotion, providing information about how to understand them and offering reminders about how to react and manage them when they emerge during therapy. According to the IRM, there are 4 central approaches to managing emotional intensity during therapy: witnessing the client's expression, showing emotional resonance, labeling the client's affect or emotional expression, intervening in the emotional expression. Emotional expression is nuanced in that it can range from being barely noticeable to being frighteningly intense. Each of these approaches to management must be appropriately matched to the unique emotional dynamic or unspoken communication occurring between the therapist and the client. If observed with empathy and intentionality, this dynamic should guide your next response. Amidst this dynamic, you should be cognizant of and responsive to the type, intensity, duration, and circumstances surrounding each client's emotional expression. Sadness is the first of the 3 categories of emotion reviewed in terms of its nature and management. Sadness. Sadness is an emotion that can occur during therapy for a wide range of reasons, most of which link back to some experience of loss. A client's experience of loss may be associated with something that occurred in the present or recent past. It may be linked to one or more cumulative events in the distant past, or it may reflect a combination of all of the major losses the client has experienced in the past and the present. During therapy, sadness may show on a client's face as sorrow, despair, or demoralization, or it may be evident in crying, grieving, or sobbing. A client's eyes may well up with tears, he or she may choke on words, or reveal his or her hopelessness or pessimism in what is said or left unsaid. When it is shared with another supportive person, sadness is more manageable for people because they feel less isolated within their own emotional state. However, people vary in the extent to which they feel comfortable sharing their feelings in your presence. In any case, you must be responsive to the variations in circumstances, intensity, and duration of a client's outwardly expressed sadness. Sadness is a given in some phases of occupational therapy. Many clients demonstrate sadness as a natural reaction to the stress they perceive or the losses of which they are reminded either implicitly or explicitly during therapy. When a client expresses sadness spontaneously or naturally, it is usually an indication that the client trusts you enough to experience emotion freely in your presence. Alternatively, it may be an indication that the client is not self-conscious or ashamed of showing emotion in front of others in general. In either case, when a client freely expresses sadness, you should interpret it as an act of sharing and welcome its expression. If you do not interrupt or interfere with this natural process, clients usually are able to collect themselves within a reasonable time frame and continue with the work of therapy. Increased trust develops simply as a product of your good timing and efforts to witness the client's sadness in a supportive and non-judgmental manner. Thus, when a client expresses sadness freely and in a way that makes sense to you, any of the following witnessing actions may be initiated to convey respect, support, and empathy. Remaining present in the room and showing respect by not talking or by casting your eyes downward, if appropriate. If it is not obvious, occasionally looking at the client rather than staring to check in and to see if the client is inviting you to share or join in the emotion. Handing the client a tissue. In the midst of his or her sadness, a client looks to you for approval or gives a searching look. It is a likely indication that the client is inviting you to increase your level of involvement in the emotional dynamic. At that point, and provided the client is not already escalating his or her emotion reaction, it is important for you to deepen your response by either labeling what you observe or by showing emotional resonance. In managing sadness, labeling is most important when you wish to preserve an emotional boundary with the client while at the same time showing support and validation for the client's feelings. An example of labeling would be making a statement such as, "I can see that you are sad about this." You may wish to preserve an emotional boundary through labeling when you suspect that the client is uncomfortable with emotional intimacy or intensity. In this circumstance, labeling may be used to give the client permission to express more emotion while still preserving the client's choice in doing so. For example, you may say something such as, "This is definitely a place where you can cry if you want to," or "Crying can help people sometimes." Or, "It's okay to cry here," or "People cry here all the time." Alternatively, you may decide to preserve an emotional boundary out of concern that the client has difficulties regulating or controlling emotions, or because of concern that the client may become emotionally dependent. In this circumstance, labeling also helps clients to verbalize what they are feeling, which generally helps them organize their emotions so that they can regulate them more effectively. Labeling is also useful when you suspect that the client may have difficulty interpreting nonverbal communication, and you want to be clear about what is being conveyed. Thus, additional examples of labeling sadness include comments about what you observe, such as, "I can see that you are feeling sad today. You seem sad right now. You are feeling deeply sad right now. It makes sense that you would be feeling sad about this. This is a very sad situation." These are merely examples. When labeling what you observe about a client's sadness, you should use your own words and make statements that are appropriate to the client and the context. Showing emotional resonance may also be appropriate when a client is sad but restricted in his or her affect, on the verge of tears, or appears to be seeking permission to express emotion. It may be communicated in conjunction with labeling, or it may be communicated in the absence of language. When you perceive that nonverbal support would be better than saying anything directly to a client about the sadness, it is best to show emotional resonance rather than attempting any other response. If a client is receptive to it, emotional resonance typically intensifies what the client is already feeling and may lead to emotional release or to more outward expression. Emotional resonance for sadness may be conveyed by revealing your own reactions of sadness in your facial expression, through allowing your eyes to fill with tears, or even through crying with the client when appropriate. If you are not comfortable sharing or exhibiting emotion in front of a client, you should not attempt to show emotional resonance for the sheer sake of trying to be therapeutic. Emotional resonance is something that should be experienced as sincere, spontaneous, and natural. As a general guideline, emotional resonance should be tempered to match the client's level of emotion and should be appropriate for the circumstances. When uncertain, you should express less emotion or a level of emotion whose duration and intensity are equivalent to those of the client, never more. Emotional resonance should be shown only if you are confident that the client will perceive it as comforting and will welcome your overture to share in something more personal, very personal. Excessive or unregulated use of emotional resonance may have the potential to be misinterpreted by certain clients as disingenuous, as a boundary violation, or as a sign that you are not in control of your emotions. Moreover, for children, too much emotional resonance may startle or distract them, or it may make them feel unsafe. Similarly, some clients react with worry or by feeling as though they must take care of you. For these reasons, you should express emotion sincerely but intentionally to meet the client's different needs. You should not express emotion without restraint or because you are forcing it as a part of intervention. Most clients, even younger ones, can sense when therapists are not in control or when they are acting a role. Sadness that is considered adaptive should not be confused with sadness that is considered maladaptive. Although it may be perfectly natural for a client to take an entire session or part of a session to grieve a loss, if a client's expression is uncontrolled or if it does not subside over the course of subsequent sessions, an intervention or possibly a referral is necessary. There are some clients for whom witnessing, labeling, and emotional resonance are not sufficient responses to sadness. For these clients, the display of sadness is so prolonged, intense, or chronic that it interferes with the therapy goals and/or with the client's occupational engagement. An example of a client who is displayed a form of sadness that was maladaptive was provided in Chapter 2. The type of sadness that may interfere with therapy can occur with a client in any setting. It does not occur exclusively in mental health settings. Other signs that a client's sadness requires intervention include withdrawal from others and/or from the activities of therapy, apathy or loss of interest in previous topics or activities, ongoing discussion of worries and problems during the therapy session with an absence of consummate work towards goal, sobbing or crying that is prolonged, repetitive, or chronic, inconsolability while expressing sadness. Although these behaviors may point for the need for referral, clients likely need to continue in occupational therapy as well. Thus, there are some interventions you should initiate when faced with these behaviors. They include reassuring the client in a way that does not minimize his or her experience, assuming a take-charge attitude so that the client can rely on someone else to take control, prescribing or suggesting interests or activities in which the client can engage, those that the client identifies as pleasurable, gratifying, or fulfilling. The client is unable to initiate these interests or activities independently. You may invite clients to join you in engaging them jointly. These are only a few suggestions. There are countless specific methods that you may use to support clients who are having difficulty with their mood. These and other interventions may be used anytime a client is sad, regardless of whether you consider the sadness adaptive or maladaptive. However, direct interventions are most likely to be effective when clients are in a significant need of support. Clients with adaptive, expected levels of sadness are often able to manage their emotions independently. Many of these clients may be most comfortable with basic efforts of validation. Attempts to say or do anything beyond validation may disrupt a client's natural ways of coping. Moreover, saying or doing too much may be perceived as meddling, intrusive, or minimizing. At times, direct interventions in a client's emotional state are perceived by some clients as excessive. If all efforts at intervention fail, you may ask the client what he or she needs in order to feel more in control. If a client is unable to answer, you should make some suggestions and wait for the client's reaction. If a client is unable to engage in basic self-care, the assistance of a mental health professional should be recruited immediately by accessing a colleague on staff or phoning the emergency room of a local hospital. In some cases, a client's symptoms and behaviors may point towards an inclination of self-harm or suicide. If there are any suspicions or concerns about the client's psychological functioning, you should always ask clients if they have any thoughts, plans, or intentions to harm or kill themselves. If a client answers affirmatively, the client should undergo an immediate evaluation by a mental health professional. Anger. Anger is a challenging emotion for many therapists, particularly those newer to occupational therapy. Despite its challenges, if expressed adaptively, it is one of the most useful emotions a client can feel during therapy. This is because anger is powerful in its ability to motivate and activate people to invest and engage in occupation. For most clients, anger is a difficult emotion to access. Many clients feel and express anxiety or sadness before they admit to or even experience any feelings of anger. However, there are other clients for whom anger is the primary means of communicating how they are feeling. Provided it is communicated adaptively, you can learn to use anger to support your clients in accomplishing a wide range of goals in therapy. Anger is challenging for many therapists because expression of anger has the potential to evoke fear, as it carries an implicit threat of physical or emotional harm. When directed toward the therapist, anger is usually more difficult to manage. Although in most cases anger does not manifest in aggressive behavior, an important point to remember is that aggression is impossible to predict. For this reason, it is important for you to know as much as possible about how to recognize and work with anger in therapy the way that preserves safety for all involved. During therapy, clients may demonstrate anger in ways that are adaptive or maladaptive. Adaptive expressions of anger may include a client discloses that he or she is feeling angry, frustrated, or irritable, and is able to describe and explain those feelings in an appropriate way. An angry or tense facial expression or furrowed brow. Irritability or frustration in tone of voice. a slightly raised voice, use of strong words or angry vocalizations, provided that you are comfortable with the language usage, the language is not directed towards other people, and it is used appropriately given the context. For example, a client grunts in frustration after attempting to string beads only to discover that they have fallen to the floor. Nonviolent, nonverbal behaviors and gestures that convey irritation or frustration, such as throwing one's arms up in the air, putting one's head in one's hands, sighing or taking a deep breath, or leaving the room to let steam off. When a client displays adaptive expressions of anger, such as these, and there is no known risk that the anger will escalate, you should support and validate the client's feelings. In most cases, this does not escalate the anger, but instead empowers the client and helps quell the intensity of the anger. By contrast, maladaptive anger should not be tolerated under any circumstance, even if demonstrated by young children. Examples of maladaptive anger include verbal hostility, making verbal threats to act aggressively, subtle insinuations or jokes that are sexually provocative, offensive, disrespectful, or threatening, deriding you in the presence of others, nonverbal behaviors or gestures that are menacing or threatening, physical acts of aggression toward objects, physical acts of aggression towards people. Anytime a client chooses to express anger in a maladaptive way is immediately a cause for concern, and it should be addressed immediately. This cannot be emphasized enough because it has implications for your safety, for the client's safety, and for the safety of others in the treatment setting. In terms of safety, signs of impending physical hostility are the most important to notice. These should be interpreted in context and may include: the client rises from the bed or chair and stands, the client's movements are impulsive, quick, or unpredictable, grinding teeth or tensing jaw, clenching fist, pacing, restlessness, difficulty articulating feelings reasonably, shouting, yelling, or other signs of verbal hostility or rage, immediate verbal threats to act, or approaching you and attempting to break the boundaries of physical space and proximity. To prevent immediate physical aggression, you may attempt any of the following depending on context: knowledge of the client's history and characteristics, and the unique interpersonal dynamic at hand. Notice the warning signs listed above and act to set limits before the behavior escalates. Set limits on verbal hostility early. Rise when the client rises. Urge the client to sit back down to talk. Instruct the client to describe his or her feelings rather than act on them. Remind the client that he or she has a choice in terms of how to communicate anger. Remind the client of the consequences for physical aggression and that behavior is not permitted in this setting. Remind clients to leave the room if they feel they may act on their feelings. Maintain a safe distance from the client or remove yourself from physical proximity of the client altogether if necessary. If timed correctly, delivered in a firm, neutral tone, and if a trusting relationship with the client has already been established, these behaviors are more likely to ensure safety than provoke or escalate a client's anger. However, with the wrong intervention, the wrong timing, or the wrong client, any of these behaviors has the potential to escalate a client's anger rather than contain it. This is why good timing and careful consideration of context are important variables to consider when deciding how to respond. It is essential that any warning about consequences be followed up when necessary. Warnings about consequences that are not followed up on only promote aggressive behavior and weaken your authority in the eyes of the client. The result will be a setting that is less safe for everyone. When clients' anger escalates, it is often the reaction to a perceived loss. At the most superficial level, clients perceive that they have lost control. This perceived loss of control may be linked to any of the following: loss of control over bodily functioning, loss of control over some aspect of one's life circumstances, loss of a skill that the client had been able to achieve in a prior session, an unfulfilled expectation of performance, loss of control over the decisions and activities of therapy, loss of the client's affection, approval, or praise, Second to validating the client's feelings, restoring control is an effective means of compensating for feelings of loss, and intervening in a client's anger. The most effective way to restore control and de-escalate the anger is to give the client as much choice over decision-making as the client is able to manage safely and responsibly. For example, when a young client begins to throw a tantrum because the therapist set a limit about entering the swimming pool safely, a therapist might say, "You have a choice. You can enter the pool safely, or you can choose an activity other than swimming for our session today." When an older client begins to lose control over angry feelings, one means of providing choice is to say, "What do you need right now in order to feel more in control of this situation?" An unemotional and non-punitive tone of voice is essential as the choice of words when offering clients a choice. When providing a client with a choice as a means of de-escalating anger, you must be certain that you are perceived as the authority figure by the client. If you do not have the client's respect, providing a choice cannot contain the situation. In some instances, it may only serve to further increase the client's anger or leave an opening for a pre-aggressive client to become aggressive. In addition, when providing clients with a choice, you must be careful not to introduce the choice in a way that punishes the client. Otherwise, the offer of a choice is not perceived as genuine. Instead, it may be perceived as an underhanded attempt at manipulation and control. Let us return to the example of the child throwing a tantrum after being instructed to enter the pool safely. If in an angry tone of voice the therapist had said, "You have a choice. You can enter the pool safely, or we can leave," the client would have likely continued the tantrum because the second limit would have been perceived as a further threat of loss. In this case, the therapist would have had no other choice but to follow through on the threat and leave the pool with the client. For certain types of clients, issuing such an abrupt consequence might have been the appropriate behavioral modification standpoint. However, attempting to understand the perceived losses that are behind the anger rather than creating new losses is often the most effective means of working with such clients. Choice is the most effective when you feel the client is capable of making a choice and that the alternative choice that you would offer would be equally therapeutic for the client. Understanding choice as it relates to a client's need for control is an essential aspect of learning how to manage anger. There are additional actions you can take to make a treatment setting more secure even before clients occupy it. This is particularly important in settings where you are likely to encounter clients with affect regulation difficulties or behavioral problems such as correctional facilities, inpatient psychiatric units, outpatient mental health centers, pediatric clinics, certain educational settings, and treatment settings where clients with certain kinds of neurological disorders are seen. These actions include using the instructing mode to gain the respect of clients and to establish yourself as the leader or authority figure, removing non-stationary objects from the room where potentially aggressive clients will be seen, memorizing the phone number of hospital security officer and keeping a cellular phone close at all times, sitting or standing close to the doorway with nothing obstructing it, leaving the door to the treatment room open or treating the client in a more public or open setting, stationing a security officer inside or just outside of the treatment room if necessary. When working with children, learn behavioral modification and safety restraint procedures if appropriate. Learning basic self-defense strategies. Designating a safe room within the treatment setting where clients know that they can go to release their anger, their aggression in a manner that is safe and acceptable. Making and posting policies that describe how anger can and cannot be expressed within the setting and ensuring that clients are aware of these policies before they enter the setting. Emphasizing the clients have choices in how they wish to express anger and reminding them of consequences for maladaptive choices. If in any setting a client threatens to physically harm or kill another individual, you should have a client evaluated by an emergency room physician or a mental health worker immediately. Law enforcement should be contacted if indicated. If you are intentional in the way that you act to reduce risk associated with the maladaptive expression of anger, your treatment setting will be safer and more comfortable for everyone. Using the strategies reviewed in this section, you can prepare yourself to assist clients in channeling angry feelings constructively to accomplish goals. Anxiety. Anxiety is the most commonly experienced and the most socially accepted of all difficult client emotions. Similar to anger, anxiety is more complex than it appears because it often serves as a mask for a wide range of painful emotions, many of which revolve around the experience of loss. For many individuals, anxiety is the most apparent of all emotions. Before an individual becomes angry or sad, you may witness a certain degree of nervousness, preoccupation, or worry. In occupational therapy, anxiety is most likely to manifest in one of the following ways: elevated or heightened pitch of voice, more talkative or talking more rapidly than usual, wringing or clenching of hands, dry mouth while talking, scrunching the shoulders, raised eyebrows or widening eyes, approval seeking or frequently questioning you about your performance, hesitating at or resisting an activity or task, high level of need for reassurance, self-doubt about performance, medically unexplained increase in fatigue, pain, or other physical or cognitive symptoms, slower than usual performance or underperformance on an activity or task. Depending on the circumstance, some of these behaviors may not point to anxiety, but instead represent a manifestation of some other emotion or issue. If you are uncertain whether the client's affect or behavior is linked to feelings of anxiety, you should look to the treatment, context, and interpersonal circumstances within which the affect or behavior is occurring. In addition, you may utilize emotional resonance or labeling in an attempt to draw out the client's emotion more vividly. Examples of showing emotional resonance for anxiety may include mirroring a client's affect, thinking about what might be worrisome for the client and attempting to feel it for yourself, admitting to the client that the situation is worrisome. In addition to helping clarify the client's individual feelings, resonating with a client's anxiety is effective when the client's worries are realistic and that you know reassurance or other suggestions would be insincere or unrealistic. Labeling anxiety is similar to showing emotional resonance in that it may highlight or activate a client's anxiety when the client is just barely aware of it. In addition, it can help clients label and make sense of what they are feeling, and some clients experience this as comforting and orienting. Finally, it may be the only sincere thing you can say to a client if the client's worries are realistic and if there is nothing that can be done about them. Examples of labeling may include stating what is observed, validating what is observed, giving the client permission to be anxious, and normalizing the worry. These and similar efforts are likely to help clarify whether a client is anxious. Validation promotes insight and generally serves to increase the intensity of the client's expressed emotion. However, if after these attempts at validation you remain unsure about the nature of the client's affect or behavior, the IRM recommends that you simply ask the client. Examples of questions that you might ask the client include, in order to assess whether they are anxious, may include, are you having any questions or concerns today? Are you feeling worried or nervous today? Does this task or activity worry you? Is there something on your mind? Is there anything about this that isn't sitting right with you? Once anxiety is identified correctly, there are some general rules of thumb that may be utilized when intervening to manage anxiety. The first guideline is to avoid prolonged validation of the client's anxiety. Acts of validation would include silently witnessing the client being anxious without saying anything, showing emotional resonance, or labeling the client's anxiety. Although these are appropriate things to do if the nature of the client's feelings is unclear, once it is established that the client is anxious, these efforts only serve to heighten the anxiety. Instead, the IRM recommends that you make one of the following interventions. Number 1. Draw more heavily on the instructing mode with the expectation that the client will feel comforted by increasing structure, repetition, guidance, and leadership. Number 2. Draw on the encouraging mode to offer incentives, provide reassurance, promote self-confidence, and instill hope. Number 3. Using the collaborating mode, make deliberate efforts to increase the client's perceived control. Number 4. Slow the pace of therapy and grade activities more carefully until the client masters and becomes comfortable with less demanding tasks or activities. Number 5. Reserve a timeout or break period in the therapy to discuss the client's worries and problem solve. Number 6. Utilize strategic questioning so that the client can begin to examine the validity of his or her worries and analyze the utility of the anxious thinking. If these strategies are insufficient, you might be interested in learning to apply more advanced mental health techniques that are specifically tailored to the treatment of anxiety. They include interventions such as systematic desensitization, cognitive behavioral therapy, and various forms of mindfulness, meditation, and relaxation training. Information on these interventions is beyond the scope of this chapter, but useful references include books by Taylor and Kabat-Zinn. Judicious use of touch. For many occupational therapists, the use of touch is a critical aspect of daily work with clients. It is central to physical rehabilitation, hand therapy, sensory integration therapies, training in assistive technologies, and other cognitive rehabilitation interventions. In the literature, touch has also been celebrated as a means of promoting communication and demonstrating sensitivity and caring towards the clients. Irrespective of whether your touch is intended to have some interpersonal effects or strictly technical outcomes, the IRM contends that the use of touch in occupational therapy always has interpersonal implications. Clients can feel it when your hand is soft, clamming, or calm, or caringly firm. Conversely, they can also feel it when your hand is rushed, abrupt, tentative, or careless. For some clients, receiving touch can be a powerfully intimate and personal experience. For this reason, the IRM considers it to be the most risky means of attempting to establish a relationship with a client. Judicious use of touch refers to knowing how to use touch in a way that respects clients' boundaries and meets their interpersonal needs, whether they be for closeness or for distance. The following guidelines may be useful for using touch judiciously with clients. When first getting to know a client, always ask and explain your rationale before initiating any kind of touch, even if your purpose of touch is only mechanical or rehabilitative. If asking the client is not possible or appropriate, announce to the client that you will be touching and explain why. Be cautious about where you are standing or sitting in proximity to the client when you initiate touch. Avoid touching clients from behind their backs or outside of their visual range, particularly without notifying them first. Be careful about where on the body you touch the client. Unless required by your intervention, avoid touching clients on the abdomen, chest, neck, buttocks, pelvic region, inner thighs, or head. If touch is being initiated strictly out of an interpersonal intervention, then touching a client's hand is the most conservative approach. Touching a client on the arm, back, or shoulder is more intimate. Even if you know the client well, avoid initiating a hug or embrace unless you are confident that it would be therapeutic for the client and that it would be experienced positively. It is always best practice to check with a parent or ask the client first. If a client initiates a hug or embrace, do what is most comfortable for you and appropriate for the situation. Keep in mind that you are not required to receive a client's request or attempts at hugging or embracing. For clients with poor interpersonal boundaries who hug out of context or hug too frequently, it is important to set gentle limits on the behavior and provide examples of how the client might express these feelings in a way that is more consistent with the nature of your relationship. Never accept requests or attempts at sexualized or other inappropriate touch from a client. These are only a few guidelines for exercising intentionality of touch. As a general rule, you should trust your emotional instincts when initiating and receiving touch with a client. The consequences for not being intentional about use of touch with a client may include triggering memories of past experiences of physical abuse or trauma, increasing the client's anxiety level, loss of the client's trust in your personal and professional integrity, the client's feeling less comfortable during therapy, the client feeling obligated to have a more intimate relationship with you than he or she desires, confusion about the nature of the relationship, the client feeling overstimulated or like a sexual object, the client experiencing pain, the client feeling emotionally or physically violated. When in doubt about the client's level of comfort and need for touch, the IRM recommends that you limit the frequency of touch or refrain from it entirely. There are many other ways that you can communicate warmth, caring, and reassurance to clients in the absence of touch. They may take the form of verbal statements, facial expressions, tone of voice, and nonverbal gestures. Cultural competence. Consider a group of people with whom you are closest. How diverse or similar are they in age, sex, religion, culture, and worldview? Do you tend to get along better with others with whom you share these things in common? If the answer is yes, you are not alone. When people share worldviews, religious or spiritual orientations, occupations, cultural or socioeconomic backgrounds, or other important things in common, they may experience this sharing as powerfully validating and comforting experience. This deep psychological need to be connected with others who are perceived as similar has been discussed in psychoanalytical literature and is referred to as twinship need. It is present in all of us to varying degrees. The concept of a twinship need has its origins in objects relation theory. According to Kohut, the need to feel almost symbiotically attached to another human being is present in everyone at birth. However, as people develop into adults, their twinship needs change and mature to varying degrees. Some individuals continue to have a high level of need for relationships with similar others. They do not tolerate individual differences well. Instead, they prefer relationships that are as symbiotic as possible. Others are able to relate effectively to a more diverse range of people, many of whom may differ from them in fundamental ways. These individuals are considered to have reached a more mature level of development in terms of their need for twinship. For some highly developed individuals, their need for twinship is no more specific than a need for a feeling of connection with others in the human race in general, regardless of the color of their skin, their religious or political viewpoints, or their socioeconomic status. Applied within the IRM, the extent to which a client and therapist are the same or differ influences the nature and course of their relationship. Consistent with the teachings of Kohut, clients and therapists differ in terms of the extent to which they respect and/or appreciate various aspects of human diversity. Human diversity is a term that defines differences between people in any number of characteristics, including but not limited to age, sex, race, ethnicity, language, disability status, religious or spiritual orientation, economic status, educational level, marital status, parental status, and sexual orientation, political viewpoint, and national origin. Our world is becoming increasingly complex in terms of cultural backgrounds, worldviews, and other social and demographic characteristics of people who occupy it. Although diversity may inspire curiosity and facilitate the exchange of new knowledge, customs, and worldviews, it is equally likely to lie at the source of misunderstanding, conflicts, lost relationships, and in worst cases, war and violence. Clients who embrace diversity are likely more resilient when faced with the fact that their therapists differ from them in critical ways. Similarly, therapists who are knowledgeable, curious, and motivated to embrace new behaviors and perspectives are more likely to relate effectively with a wider range of clients. Consistent with the Occupational Therapy Code of Ethics, the IRM emphasizes that it is not the client's responsibility to manage the complexities introduced by diversity in the therapeutic relationship. Instead, you are responsible for possessing the cultural competence necessary to be able to adjust your practices to better understand and accommodate the ways in which you differ from your clients. To achieve intentionality, the IRM assumes that we are all more comfortable relating to others like ourselves. Thus, the model asks us to step outside our comfort zones and learn to relate with and be guided by unique ideologies and behavioral practices of our diverse clients. The extent to which you are able to do so depends in part on the specific individual differences that arise between you and your clients. Because a comprehensive and in-depth review of cultural competence is beyond the scope of this chapter, readers are referred to two excellent occupational therapy texts. The text by Bonder and Associates emphasizes self-reflection, assimilation of culturally relevant information, and practice guidelines for work with diverse populations. The text by Wells and Black focuses on explaining the rationale and importance of becoming culturally competent, and it offers information about healthcare beliefs and behaviors of specific cultures so readers can begin to expand their knowledge base. Summary. Establishing functional and trusting relationships with clients is not always easy, particularly when clients are interpersonally challenging, show difficult emotions, have issues related to touch, or differ from you in ways that they perceive are critical to the relationship. In this chapter, I reviewed 5 critical interpersonal skills that are required for establishing effective relationships with clients. They included rapport building, mode matching, and versatility, managing emotional intensity, judicious use of touch, and cultural competence.